I'm going to go ahead and get us started. It's great to be back with all of you tonight. It's been a while since I've seen you, so it's very exciting for me to join you again for tonight's presentation. I think the title of tonight is Anxiety, Depression, and OCD Identification, Diagnosis, and Support, or something like that. So we're going to try to give you as much information as possible in the time that we have to support people who are experiencing anxiety, depression, OCD. Try to figure out how to identify the things that are going on, understand them a little bit more, so that you can be the best support possible for the women in your communities. I have with me Regine Galante, who is a psychologist, and I've worked with her in the past, and it's always been a pleasure. So it is exciting for me to also be here presenting with her again tonight. I am Shira Donath, for those who I have not met or who weren't in the first class. I am also working in private practice as a psychologist in a practice that specializes in OCD and anxiety disorders. So this class tonight is very familiar to me in different realms. So I'm going to be talking about more of the application of this, so how you'll see these disorders come up with women in your community, if women are calling you with questions, how to identify what's going on and understand the best ways to interact with this woman to help her. Regine, do you want to introduce yourself?
Sure. So I'm Regine Galante. I'm a psychologist in private practice in the Five Towns, so in Long Island. I run a practice called Long Island Behavioral Psychology, and I focus on anxiety and OCD mostly, and I'm a cognitive behavioral psychologist. So I focus on helping people really change their behaviors in order to create meaningful change in their lives. And I also write some books on anxiety, but mostly for kids. So that's a topic for another time.
Dr. Galante's books are excellent, and I highly recommend them. I've used them professionally and personally, so they're always great resources. Do you want to get us started with some information about all of these disorders?
Sure. So what we're going to do is I'm going to give a background, and then we'll open it up to questions and more discussion and applications. I want you to know also, just a big disclaimer, is anxiety, depression, and OCD. Each one of these could be year-long talks, right? Like those are three different specialties. So I'm going to do the best I can in a short amount of time to kind of give you a frame to work with, to understand how these work. But I always, when I'm talking to lay leaders, like to start off with the caveat that you should know your role in this. And that's not to treat these things. So it might be to detect, and it might be to get people to the right place, but it probably shouldn't be to implement the strategies I'm talking about. It's more that you should know what those strategies are, and be aware of them and help women get them through people who know, who have expertise in these. But I think that the more you know, the easier it will be to achieve that goal. So with that caveat in mind, I really want to start broadly because, again, these are three big topics in different areas. And really start talking about what emotions are, because it's funny, I tell people all the times, like the parents I talk to, the kids I talk to, I'll say, okay, name a feeling. And those are easy, right? Happy, sad, angry, whatever, anxious. Typically that one comes up a lot in my practice. And then I'll say, okay, so what's a feeling? Like, what's an emotion? And even adults will be like, I don't know, happy, sad, they'll give me the same answers. So it's funny because we walk around with these things all day long, and I don't think many people sit down and say, okay, what is it that I'm walking around with? So I like to start off there. And I like to tell everybody that emotions are, I start telling little kids that emotions are a feeling that comes along with a physical reaction. And some of the discerning features of emotions that I like to start with are that they're normal, which means everybody has them. Even if they're uncomfortable, even if you don't want to have them, you can't say, well, I choose not to be sad ever, or I will have no anxiety in my life. Everybody has them. little kids are always shocked to be like, really? Even my parents have anxiety? Like sometimes. So I think it's a good kind of tact. And as much as adults know that everybody has feelings all the time, it's funny because then when, you're hit with like, let's say feeling sad and you don't want to, you forget that you kind of can't turn off your feelings and say, well, I don't want to be sad now. You can try to do that. It's probably not going to work out so well because feelings are normal. Um, Feelings are also natural, meaning they're adaptive. God created us with feelings for a reason. Um, and turning them off would be a bad thing. So anxiety-free living, I like to say all the time, would be stupid and dangerous. People who have no anxiety walk into streets and get hit by cars, right? Like they jump off cliffs. They do things that put their bodies in danger. So even if a feeling might be uncomfortable, it's designed to help us survive, which is a good thing. So we'll talk about like a little bit later where that goes wrong. But baseline, we have to feel sad sometimes. We have to feel anxious sometimes, because if not, we do stupid things, and that's not good. And then the third thing you should know is that the emotions themselves are harmless, meaning they can feel really uncomfortable, but they can't hurt you. So the prime example I always give for this is one anxiety disorder that I treat is panic attack or panic disorder. So it's a lot of physical symptoms of anxiety all at once. So your heart races really fast, your breathing speeds up, your stomach can start to hurt, your muscles tense up. It feels really uncomfortable. And people always tell me, well, my body feels like it's in danger. Something's wrong. Something's like this is dangerous. And the truth is it's not, because anxiety is trying to get you out of danger. And it could be really uncomfortable, especially when it's to that degree, but it's harmless. If you sit through a panic attack, nothing will happen. And honestly, that's to get very ahead of myself. That's literally how we treat panic attacks. We teach people to sit through them and do nothing, and then they get better. But that is right, like for a little while from now. So normal, natural, and harmless. That is kind of the premise of what I need you to know that's going to underlie anxiety, depression, and OCD. Because when I was thinking about this talk, again, I can do a 3-hour talk on OCD alone. So thinking about how to approach these very disparate areas in mental health, I was thinking more about like how to give you more a united view so that you could understand how emotion can be healthy or unhealthy and how it plays a role in people's functioning or dysfunction. That might be useful. To go back to one of the ideas I already touched on, when you have a feeling, it pulls for a behavior, pretty much always. So I'm going to ask for some participation. I hope that's okay. I want you to think about like when you're afraid of something, what does it make you want to do? Like if there's a tiger in the room, this is a very psychologist example. If there's a tiger that shows up at your door, what are you going to want to do? Something in the chat. Run, right. Makes you want to run. So that's the behavior that it's pulling for. That's a good thing because, again, running people are more likely to escape tigers than people who take naps and don't move. So it's a good thing to run. And the emotion pulls for running. It says, okay, run. Every emotion has that one. Fear is kind of the easiest one, but when you're sad, what does that one make you want to do? It's a little bit harder. Cry. So that's how, like, that's a feeling that you have in your body. And when you think about like, so when you cry and you're low energy and you're sad, do you want to do so much stuff? No, you kind of want to withdraw and like be alone. And it's like from an evolutionary perspective, that seems like a healthy response to kind of give you time to process grief. It's not good to be sad and to just jump into something new. Like if you think about people who like are in serious relationships and then break up and feel sad, and then the next day they just jump into a new relationship, our gut reaction is typically, wait, that's not so healthy. So the adaptive response that kind of takes up time and be like, what just happened, is a good thing. I'll do one more. Anger. So what behaviors does anger pull for when you're angry? Yelling. So um, it, when you're angry, you might yell. Um, I like to give the example for anger of, if you think about, like, if I don't know, if I go up to Shira and we work together and I say, oh, I forgot my lunch money, can you lend me $10? And she does. And then and I say, okay, no, we're like, I'm definitely going to pay you back tomorrow. And then tomorrow I come and I say, oh, I forgot my lunch money again, can you give me another $10? And she says, oh, sure, but now you owe me $20, you should really pay me back soon. And then I go, like, it's like 4 or 5 days running. um, Eventually should start to get kind of mad at me and be like, no, like, you need to figure something out and pay me back. So that anger lets her set her boundaries. And by setting her boundaries, I don't get to step all over her anymore. And that's a good thing. So people who don't feel anger sometimes are too passive. So that's another way that, like, emotion pulls for a behavior that's probably, if you're a caveman and you're giving away all your, I don't know, caveman stuff, it's not good for survival. So you want to set that boundary and be healthy. So I can play this game all day with every emotion, but I think it's really important to understand that the way I see it is emotions exist on this spectrum. And it's not like depression and OCD and anxiety are unhealthy, and then like sadness. And I don't like that we have the same word for healthy and unhealthy anxiety, but I guess it works better for this example that emotions are on a spectrum. So we don't have healthy on one side and unhealthy on the other. We have like this spectrum of, there are feelings, and they pull for certain behaviors, and sometimes those behaviors get out of hand and out of control. So that's the premise that I work with in therapy. So these are the things we just talked about. When you're afraid, you want to run away. When you're sad, you want to withdraw. Happy works the same way, by the way. It's like when you're happy, it feels good and you want to do more of the things that feel good, which is also good, because like that's adaptive too. You want more happiness as opposed to the others. You're trying to get rid of the others. I should also mention, I don't like saying an emotion is kind of bad or good. I think they're all healthy and adaptive in certain circumstances, but there are ones that obviously are way more uncomfortable than others. Nobody likes feeling sad. Most people don't like feeling anxious, but if it saves you from a dangerous situation, that's a good thing. Or if you're not sad, when you're trying to process the loss of someone close to you, that would also be a problem. Um, with some caveats, I would say, like, numbness would also be like a totally normal kind of reaction to the loss of someone. Um, so emotions are helpful because, again, they protect us and they let you set those boundaries and avoid dangerous situations. But the problems come in when emotions get it wrong. So kind of like, if there's a tiger or a big truck coming towards you, or like something's happening to your kids and you react with anxiety and fear and you avoid the situation, then that makes total sense. But what happens when, I don't know, there's a dog walking down the sidewalk and you react as if the dog's going to bite your head off? Then all of a sudden we're not in adaptive versus not adaptive territory. We're in the territory of what I call a false alarm, right? So it's when the smoke alarm goes off in your house and there's no fire, but you react as if it's a fire. And if that happens one time, everybody totally understands. But if it keeps happening over and over and over, and you keep reacting like there's a fire, we're going to say, hey, you got to change your response here. The firemen are going to come and be like, you can't keep calling. Like, just look around and see if there's a fire first. So I like to think of emotions as informers, but they're not directors. So they give you information, and then it's our job as human beings to say, is that information true or not true? We've all been in situations where, I don't know, someone's like standing in a spot in the kitchen where you don't see them, and you walk in and they say hi and you jump. So, right, that's a fear response. You have to recalibrate very quickly and say, oh, okay, nothing's wrong here. Or like, you're sad for no reason, and then you realize like you're being a little too hard on yourself and you pick yourself up. So these are normal ways where kind of our emotions lead us in directions that aren't so healthy. But if you're a relatively healthy person or you have positive coping skills, you say, okay, like, yeah, I'm afraid of flying, but I recognize that it doesn't really make sense that I'm afraid of flying because, I'm much more likely to get into a car accident than get into a plane crash. And then you get on the plane and you might be scared for a few minutes and then you fly. But for other people with anxiety disorders, they don't take that second step. They say, okay, nope, flying is too dangerous. I'm not willing to risk it. And that's where the emotion system kind of goes. The emotion system doesn't go wrong, but the problems come in. So at any point, by the way, if people have questions, I am flexible. I can be interrupted. I might not get back to where I was going, so that's the only thing, but feel free to ask anything. So to put all this together and add a little bit more, the way I understand emotions is through this cognitive behavioral therapy model, the CBT model of emotions. And the way CBT understands feelings is that they're made up of three parts. There's always a thought, there's always a physical reaction, and there's always a behavior. So I'm going to go back to anxiety and my tiger example. If there's a tiger at my door, so that would be my situation or my trigger, because there's also always a trigger for your behavior. So, or for your emotion. So if there's a tiger at the door, that's the trigger. My thought might be, I must be in danger. Anxiety typically always boils down to danger. And I'm also going to have this major physical response, right? My heart's going to start beating. My breathing's going to speed up. My muscles are going to tense. My stomach's going to hurt. My pupils are going to dilate. And I'm going to be hyper vigilant and searching for where that tiger is, right? And because of that thought and physical reaction, I'm going to want to run away or fight the tiger if I can't run away. And that happens in situations like tigers, but it also can happen in the situation of me remembering a scary situation. So like, oh, remember that time I got stuck in the elevator. And then I think back and I'm like, oh, that felt so uncomfortable. Like, right. Like I wasn't sure when I would get out. I was afraid that I was in danger. Again, always gets back to danger. If you pay attention, when you are anxious, like when you're thinking anxious thoughts, you typically have some kind of physical reaction to. This is true of pretty much every emotion. Again, I specialize in anxiety, so that's where my examples kind of pull me towards. But people don't notice their physical reaction as much as I would argue they should, because they're such a important part of your emotion. And that's why it's so hard to just kind of think logically about things that you're anxious about. Like if you're convinced that your kid's bus, something happened to it on the way home, even though you know that that has never happened before and it's probably not the case today. So that would be like a thought strategy, me trying to say, okay, that makes no sense. It didn't happen. But that's very hard. And one of the reasons why it's very hard is because your body doesn't agree with your thought. Your body's telling you otherwise. Your body's saying danger, 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 danger through muscle tension, through breathing heavy, through heart racing. And when that happens, it makes you want to act. It makes you want to, in the case of anxiety, run away or figure out what the problem is, call the bus company, text the older kid on the bus to check if your kid is okay. And the problem is that if there's no danger, what you've done is create a loop. So if you see in my little triangle, you're creating a situation that next time the bus is late, your brain is going to jump quicker to the fact that maybe something is wrong. So you basically kind of like when you feed an emotion cycle, regardless of whether it started with real danger or not, you allow yourself to say, okay, that smoke alarm might be fire next time. And if it's fire next time, I need to respond quicker. So that's kind of the way I understand all emotions, that there's always going to be a trigger, something will happen. And then if you maintain your behavior, the problem's going to get worse instead of better. So this is only in situations where you are safe. If emotion is actually giving you a real safety signal, like it's really saying, hey, go do something and to be safe, then obviously, like, that's why it's there. Then you go and you do the thing. You say, okay, like, I witnessed a car crash, I'm going to go, like, react to it appropriately. But in situations when this is anxiety or this is depression, and the way this would work for depression is the thoughts would be a little bit different. It would be like, I'm a failure or nothing will get better. And then the physical reaction in depression is a little bit different. It's a little bit more fatigue, heaviness, like almost like you're carrying a backpack, or like a ton of bricks. And then your behaviors are really about withdrawing. It's about like closing yourself in. So then you don't get the feedback that you need of, hey, things are not as bad as you think they are, because you're not going out, because you're saying, okay, I'm too tired and nobody likes me anyway, so why should I go out? And then you don't pick up when your friends call, and then you feel worse about yourself. So again, you're kind of stuck in this cycle. But the trick is, and this is what I know as a therapist that most people don't, is that emotions fade if you give them time. That's why you're not the happiest that you've ever been in your whole life in this moment, right? Like, because happiness fades, but so does anxiety, and so does even sadness. I always give the example of, like, if you've experienced a loss, and at the beginning it feels like your things are never, ever, ever going to get better. Like, it's just, I'm going to miss this person forever. And it's not that you don't miss that person forever, but the process can take years, but over time, it becomes much, 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 much easier to cope with losing someone. That's because emotions fade. So literally my goal of therapy is to give emotions time to fade without doing anything. So that has different kind of implications with anxiety, depression, and OCD, but that's the general gist of what I'm trying to do. I'm trying to give those emotions a chance to fade without doing any unhealthy behaviors. I think I already said this, but I will repeat myself. So emotions can be false alarms, right? So like what emotions want you to, so it's actually just review, so that's okay too. So what emotions want you to do always is act. So they don't care about whether it's a tiger or whether it's a stuffed tiger or whether like it's something you should be afraid of or not. It just cares that when you have anxiety or when you have an emotion, the goal is to respond to it. It has like, it's very kind of, if you view emotion as an actual person, which it's not, it would be very single-minded. And the goal of anxiety is always to get you to escape or avoid. And the goal of sadness is to kind of get you to think and process and kind of stew in it. So the way this plays out is with anxiety. If you actually listen to everything your anxiety wanted and avoided, it might be someone who stops driving because they're afraid of car crashes, or someone who doesn't go out with their friends because they might say the wrong thing. So they feel anxious about saying the wrong thing. And then they say, okay, how do I get out of that situation? Maybe I just won't go out. That'll be easier. And they avoid their anxiety, but they also create more problems. Or for OCD, which I'll talk about a little bit later in terms of how exactly OCD is the same but also different. OCD involves these intrusive thoughts. So that's the obsessive part, the O. Intrusive thoughts are normal. If you've ever taken the subway and thought to yourself, oh my gosh, what would happen if I drop something? Would I jump down and get it? Could I get back up? That's an intrusive thought. Everybody has them. Or like, what if I stepped off the curb too quickly and got hit by that car? They're weird and random, and they happen. They're normal. They seem scary. So what people with OCD do is they have an intrusive thought and they act on them. So if I have a thought like, hey, what if that subway killed me? You take 3 steps back just to be safe. Or you think, oh, did I wash my hands after I changed my baby's diaper? And you're pretty sure you did, but you're not sure. So you say, you know what, let me just wash one more time to be sure. But the act of washing again actually creates more anxiety, not less, because it gives immediate relief. But then there's kind of like a boomerang effect with emotions that if you feed them, they come back and they hit you in the head. So then it's next time, it's like not only one doubt, it's maybe 2. It's like, I thought I did, but maybe I didn't. So you almost undo all the confidence by doing things more. Or like, maybe I'll just say one extra prayer or a parak of Tehillim just to be safe, right? Just because I had this bad thought and I should get that bad thought out of my head. So I'll just just to be safe. But next time it's 2, and next time it's 3. So these things kind of grow and grow. With depression, the way the emotion kind of gets you to act, like I mentioned, is to withdraw. So you're feeling tired, so you don't want to go out. So then everybody has always had most people have had the experience of, I'm not in the mood to go out. And then you go out and you have a good time anyway. And you're like, oh, this was a good idea. So depression is with depression, often that go out anyway doesn't happen. And then it becomes a self-fulfilling prophecy. And since you're not acting, it's harder to act. And since it's harder to act, you stop acting. And people stop reaching out when you stop going out. So it can be like a very dark kind of negative spiral. So big takeaway is that the emotions are always real. I always tell people it's always okay to feel your feelings, whether or not you want to. You kind of can't prevent the feelings from happening, so you might as well feel them. But the way I see it is the problems that happen are with the reactions that you have to your emotions. So if you're afraid of flying and you start avoiding flying because you're afraid of flying, that causes the problem, not the fear of flying. The fear of flying is just a fear. Fear is okay. So if you continue to avoid or withdraw when you're safe, you make the problems worse. So that's really like the beginning, middle, and end of therapy. And everything that I just told you are things I go through with my patients. I'm very upfront with them about the way I see emotion and what our goals are. So our goals are to actually I'll go back and then I'll go forward, is to do the opposite, right? So you feel a certain way and you want to, let's say, avoid or withdraw. Our goal is to switch it. So instead of avoiding or withdrawing, you're approaching. It's all about approach, I guess. But one other idea I really want to highlight is that when you're dealing with something I call the short-term, long-term problem. So when you're dealing with these false alarms, what makes you feel good in the short term, like avoidance, right? Like not going out with your friends, creates negative patterns long term. So when you take a nap because you're depressed, you avoid all your negative feelings while you're napping, but then you wake up and the depression hits you like a ton of bricks. Or when you avoid your friends because you're anxious about what to say the next time, you have no idea. You have to make up why you didn't show up last time, and also figure out how to be socially with it and on this time too. Or with my teens, I always give the example of let's say you have a homework assignment due next week and you're not sure what to do. And you say, oh, I have a week. It's fine. I'll just turn on Netflix and watch a show. I'll deal with this tomorrow. So you avoided your feelings and now it's the next night and you're like, oh, I should really get started with that paper. And you're like, oh, I still don't know what to do. Okay, you know what I do yesterday that made myself feel better? Oh, I watched Netflix. I'll do that again. So now you keep cutting down the amount of time you have to do the assignment while the anxiety increases because you end up with less and less time to actually do the task. So the anxiety is going up, but the coping skills are going down. So that's the kind of short-term, long-term problem we have. And the opposite happens when you actually approach, or in treatment, doing the quote unquote right thing that'll help you long-term is super uncomfortable short-term. Right? If I'm afraid of dogs, going up to a dog and petting it seems like the stupidest thing you could ever do in your life. But long-term, it's helpful. So if you have OCD about checking, right? You can have OCD, any obsessions are not only about cleaning and checking. That's another thing I just want to put out there because it's really important. People think, oh, I don't have OCD because it's not about cleaning and checking. That's not what OCD is. It's just about having intrusive thoughts and dealing with them in a specific way that's ritualized. So this example plays right into the stereotype because it is a checking example, because that is a subtype of OCD, but it's not the only one. So I'm saying it. So if you're OCD about checking, if your locks are locked and you go and you check them, you'll feel good right away. But in 10 minutes when you're sitting and reading a book, and you think, wait, did I check the locks? Maybe I unlocked it while I locked it. You're creating more problems. So, like I said, what the treatment really involves is doing the opposite, especially in CBT. Again, I'm a behavioral therapist. So changing your behavior is my go-to strategy. So for the case of anxiety, the research-backed treatment that works for anxiety is called exposure therapy. It's when you face your fears over and over, and they stop, and basically you kind of reduce the strength of the fear, and you help people learn that they can cope even if their fear comes true. So this is not like I'm not going all like fear factor, throwing people like into snake pits or whatever, unless that's the way they choose to face their fear. Um, it's really more about like taking steps slowly towards what they were afraid of. Um, and very similarly for OCD, what we're going to do is exposure. So helping them face their fear with something called response prevention, which means not allowing them to do some of the rituals that they generally would do around their their thoughts. So if you have, if you're worried that there are germs everywhere, what we do is something like have a patient stick their hands in dirt and not wash them after. So it's not enough to kind of face the fear in the moment. It's also about learning that like it's really okay to face the fear. And yeah, is that gross? Absolutely. It is definitely gross, but it's also not like most people don't walk around terrified that they'll get cancer from having dirt on their hands. So the fear doesn't match up with the realistic situation. And that's why we engage in approach behaviors for treatment. And then the last kind of do the opposite is for depression. And that's depression. In depression, you often people withdraw and stop doing the things that they are interested in and value. So the focus in treatment is all about it's a treatment called behavioral activation, which means really doing stuff. It means like having people make a list of the things that they used to do before they felt depressed that made them feel good and doing them anyway. And what stinks about this treatment is it often doesn't feel good right away. Like if you're feeling depressed and you start doing all the things that you used to do, it doesn't automatically, for most people, give them that like mood boost. But it does feel better than it did without doing those things. So it's a good place to start. So basically, all these different treatments focus on recognizing that the emotion is not actually keeping you healthy and safe. So instead of doing what the emotion tells us to do, we're going to do the opposite of what that emotion does. And learning that, okay, like emotions fade with time. So with anxiety, the emotion goes up. And then if you do nothing, it gradually comes down. So if I know that, then my plan in therapy is always to just buy time instead of actually trying to do like, let's try this strategy. Let's try that strategy. As long as I can kind of say, let's wait this out, things get better. So that tends to be my approach in a nutshell. Um, I don't know if this is too small to read, and I know Shira's going to start jumping in now when we talk about the specifics, because I know that's a very big overview. So now we'll talk about some specific examples. But like I mentioned with CBT, the CBT model, there was always thoughts, there was always a physical reaction, and there was always behavior. So when we're talking about anxiety in general, these are some of the typical thoughts and the typical physical feelings and the typical behaviors. So thoughts are always about danger, worrying about bad things that might happen. Thoughts are images of bad things that might happen. And then physical feelings are heart pounding, numbness, irritability or anger. Anger also has like a big place in like irritability specifically. If you think about it, if you're too fidgety, then like it gets to the point of like irritability almost. So I will interrupt myself and just mention that anxiety doesn't often look like people expect anxiety to look. People expect anxious people to be shy, or like, I don't know, hiding in the corner or something. I love working with anxiety because I feel like I'm working with just like people I know. Like they're people that could be my friends. They just are anxious about specific things in specific ways. So just because someone is totally, let's say, socially competent and extroverted doesn't mean they're not anxious. So that's a heads up. There's also a lot of muscle tension, nausea, stomach aches, trouble concentrating. oops, sorry, I jumped ahead. And then behaviors, like I mentioned, it's all about avoidance. So avoiding situations or people or things. Um, Sometimes it's not about avoiding things completely. It's about avoiding them in a certain way. So like I'll only drive if my husband's in the car. So that might be an avoidance. Like what's your husband gonna do? Jump over and grab the wheel, like stick his foot like where the pedal is? That's not a thing that can actually probably keep you safe. Um, right. For little kids, it could be temper tantrums when they're faced with their anxiety. Um, or like this list actually, now that I noticed, I grabbed it from somewhere else. It has a little bit of OCD flavor to it, but that's okay. So I'm gonna let Shira jump in here with her just some application stuff about anxiety. I grabbed this from one of my books to show you how this all fits together. Like if someone's afraid of spiders and then they run from spiders, they're gonna feel better, but then they're also gonna build that belief that they can't handle spiders, which means that next time they see a spider, the spider somehow grew 6 inches and now they really can't handle it. So that's the cycle that we're trying to break, but not with spiders. I guess also with spiders, but also with things that are more relevant to you, which we'll talk about now.
Thank you, Dr. Galante. That was awesome. Very practical, made it very understandable. Before I jump in with some practical applications, does anyone have any questions about anything in the presentation so far? You can either unmute yourself or put it in the chat box. No? Okay. So then I'll just jump right in. So I'll talk first about anxiety, and then we'll move on to the other disorders. So some of the ways that you might see anxiety popping up with women in your community through their asking you Taras HaMishpacha questions can be just like noticing that the woman is worried a lot about if she'll become Nida. If she just like keeps saying like, well, what if I become Nida? What if I become Nida? Or if they start to avoid finding out that they're becoming Nida. So there's this idea of like not looking when you go to the bathroom to see if you've stained. So that is normative because women are often advised to not look to avoid becoming Nida from stains. But if women are telling you that they're like avoiding going to the bathroom all day because they don't want to find out that they've become Nida, they don't want to see a stain because they won't be able to handle it. And women have told me this, that they've avoided going to the bathroom all day because they're afraid of finding anything. Then that could be a potential red flag that there is some anxiety there that's going on. Sometimes women will become anxious about doing bedikot. So if a woman is asking you if she can reduce the number of bedikot and there doesn't seem to be like a real reason to that she should be reducing the number of bedikot, then you can kind of probe a little bit to find out what's going on there. Somebody could have anxiety about the mikvah or mikvah preparation. So sometimes women will come up with excuses for not going to the mikvah. So with all of this, you don't want to jump to conclusions because there can be any number of reasons why women are coming up with excuses to not go to the mikvah. But one of the things that could enter your mind is, I wonder if this woman has anxiety about going to the mikvah. They may just try to push it off for as long as possible, claim that they've had stains that have made them Nida, they restarted a flow. So whenever women are telling you, and you see this pattern of women pushing off the mikvah, and it seems to be like an unusual pattern, that's something that you can explore with them. Some women may have a specific phobia, like water can be an issue for some people. I know a woman who had to accompany somebody else to the mikvah every time that she went to the mikvah because just having the mikvah attendant there wasn't enough for her. She was terrified of the water. So this woman should have been in therapy, but she wasn't. So this woman I know accompanied her actually into the mikvah water so that she would be able to go through with her dunk. For anyone who teaches kalas or has young women in your community who have recently gotten married, the transition to marriage in terms of sexuality could be particularly anxiety provoking for women. And so that could be another reason why women are avoiding going to the mikveh, or, it could be something that they're particularly anxious about. Sometimes people will ask questions about sexuality, or beat around the bush about it, but it seems like that might be where they're going with their question. And so if someone seems to be like very hesitant, or it seems like they're more nervous than you would expect them to be, that's also something that you can explore with them. Obviously, for all of this, there could be other things going on, like an unhealthy relationship, abuse, that could be contributing to the anxiety, which is, like Dr. Galanti said, there could be in certain situations an extreme fear response that is in response to an actual threat. And so that's something that would be important to determine. Is there an actual threat going on for this woman, or is it just this irrational anxiety that is causing her to engage in these types of behaviors? For depression, it might be harder to identify what's going on. Often I notice that it'll be in the way that somebody is talking to you, or the way that they're responding to your suggestions or your answers or your questions. If they seem to be like very lethargic, or they're just like not motivated at all, like they'll call you with a question about a badika or getting to the mikvah, and you try to help them get to the mikvah, and they're like, okay, maybe, or maybe not. Like they're just like not seeming to be very motivated. That could be a sign of depression. If there seems to be a very big change from how they were previously, that's always something to look into. If they seem like very foggy in their recollection of events, that could be an indication of depression. Sometimes women will kind of forget the timeline of things. So they forgot the day that they got their period, they forgot the day they did a hefsek, they forgot when they did batikas. So some women struggle with executive functioning skills, and some women are just kind of, flaky or spacey. But if it seems like unusually, like unaware of what's going on, to the point that they're just like not seeming like they're functioning well, then you can always ask a question like, "Are you okay? Is everything okay with you?" Just to kind of check in to see if there is some depression there. If a woman has OCD, that could also play out in a number of ways.
I'll also just add that in the realm of Taharat and Mishpacha, I think depression is probably the hardest one to detect from the outside. So it's something, definitely be aware, like look for signs, and don't be afraid to ask. Also, like if someone like bursts into tears, like just like letting things go. We know actually from the research that it's okay to say, hey, are you okay? And are you safe? Like as a therapist, one thing that I teach my kind of junior therapists is that like it's even okay to say, are you thinking about hurting yourself? And that doesn't put thoughts of suicide in people's heads. It's actually helpful. So I just want to put that out there in terms of like knowing that if you do see kind of something that's very out of character for someone and super sad, it is okay to kind of just say something.
Yeah, absolutely. Thank you for jumping in there with that.
Can I ask a question on that?
Yeah, go ahead.
So like recently, like my husband and I had a family over, and like when the family left, we were both kind of like, the husband seems depressed, but we don't know his baseline. But like we also didn't want to overstep by asking, and like we are newer to the community, but it's like I was trying to sure like how to like. Do you think it never hurts to ask, or sometimes like it does hurt to ask, and like you shouldn't?
I think it depends on your relationship with them, and what you are seeing from them when you had them over. So some things could just be his baseline, that he has kind of a low, less affect showing than some other people. But that could also be indicative that it may not be depression, it could be something else going on. Um, I, I think I lean towards like try to reach out to build more of a relationship and see what comes up, or like try to see what your points of contact point to. So like if your husband sees him in shul or runs into him somewhere, like trying to see if it still strikes him as seeming depression like, then that may be more of an invitation to ask if he's okay. Dr. Blonde, do you have anything else to add?
Right. I think in the situation you're describing, it's more like, hey, are you okay? Like, or like you're saying, relationship build. But sometimes kind of depression spills out of people. And in those cases, it's okay to push a little bit more. Like, meaning someone's sobbing kind of on your lap when you don't know them, like people have those moments when they're just like, I remember once I was walking through Costco and some woman that I met once stopped me to tell me her daughter had cancer. I was like, oh, okay. Like that, sometimes things come out like that. And those opportunities you can push. And you're probably in those roles more than I am with people that you're not already connected to. So,
yeah.
Question about anxiety.
Somebody's talking. I can't hear you very well.
Do you hear me?
Yeah, now I can hear you.
Hi, sorry. Yeah, I wanted to just jump back to anxiety. I had a question about that.
Sure.
So sometimes when I work with Kalas, I'll see like a Kala who has kind of like an anxious presentation, and between wedding planning and starting birth control, she feels like out of whack. It happened like a couple times recently, and they want to put it a lot on the birth control, which is possible. But to me, I see like more of a thematic. They're anxious about a lot of different things, and this is not probably so new. So I was just wondering, like the combination of those factors. They're at an anxious time in their life. The birth control certainly is new and can be affecting them in that way, but really this looks more like a consistent mental health issue. And I was just wondering how to navigate them. I don't know them well in this setting oftentimes. It's not someone necessarily from my shul that I have a long-term relationship, and just tips on how to navigate that or how to put them in the right direction when they're also like pointing to all these other things that they're putting their anxiety, like, oh, that's why I'm feeling this way.
Mm-hmm. Dr. Glanti, do you want to?
So I think you might have more of again, the communal lens, but I'll say that the number of people who have showed up in my office to say, like for a consult, to say like, well, is this something that needs dealing with? And it hasn't needed dealing with. I can count on one hand in the course of my career, right? Like people don't come to therapy and say, is this an issue for me to say no? Like once in a while, if the parents are super anxious and they bring their 2-year-old in and you're like, your 2-year-old's a 2-year-old. But even then, it probably is worth working with the parents because, right, like you're really anxious that your 2-year-old is going to be an anxious 2-year-old, which will make them an anxious 2-year-old. So if you're seeing those multiple points, yeah, the chances are this person could use some professional help, whether or not it is the birth control. So my tact is always to just really work on normalizing therapy and like kind of using an expert. Like, okay, maybe she doesn't need therapy, but it's a tricky time in her life. Like she's getting married and she is on birth control. And there's probably a reason why she's on birth control. Like she wants to make sure that she doesn't have her period at her wedding. And if we go messing with that right now, like right while she's engaged, that'll cause other problems. It's probably more worth your time to have her talk to someone about some of these things, even if it's for a few sessions. So that's the fact I like to say. Like, yeah, no, it's not that she needs therapy. It's just that she should talk to someone to help her out in this kind of difficult position that she's in right now, even though probably it is an anxiety thing. So, but I've often found when people come at it like, right, they're always looking to blame the straw that broke the camel's back instead of saying like, look, it's that whole mountain thing that's going on below it. But Shira, I'm curious about what your
Yeah.
advice would be.
So I think people will have like their tendencies, right? Like if somebody tends to be anxious, that's gonna permeate everything in their life, and it's gonna heighten when they go through stressful transitions and times. Um, I see Kalas who tell me that they're anxious, and then they become super, super anxious all of a sudden. And sometimes it's in response to birth control starting. Sometimes it's not. Sometimes it's just really stressful to have a wedding that's coming up and a lot of transitions that are going on with it. In terms of the birth control piece, birth control can wreak havoc on people's brains. I've seen everything from someone becoming immediately actively suicidal within a day of starting birth control to just like becoming a little more anxious or a little more moody. And so how someone reacts it varies from person to person, and within one person it'll vary depending on the pill that she's on, the dosage of the hormones that are in the pill. And so I have a conversation with Akala, hopefully before she starts birth control, about potential side effects, things to look out for. And we also talk about like pros and cons of being on birth control. And if somebody starts to notice that they're having emotional side effects or physical side effects, we talk through like, is it worth it for you to stick this out in order to be on the birth control? Or is it so damaging to your well-being that it's really not worth it? And you'd rather risk just, going things naturally or trying to find a different hormone that could help you without potentially having as extreme side effects. So it's not like a simple answer of like, this is what you should do in this situation, but I do think it's worth exploring with each person individually, all of those different factors.
I'll also mention, I don't know, Shira, you've had the same experience, that oral birth control seems to be the most anxiety kind of producing, like people who have the NuvaRing or something like that. That seems like a much better option. Or like the married women I see, if like an IUD typically is a lot less anxiety provoking than those. I don't like the words I'm using, anxiety provoking, but anxiety producing. Right. It seems like things that go through your whole body, like right, kind of head down, seem like the most anxiety.
Yeah. So the combined estrogen and progestin birth controls that are taken orally, especially those with higher dosages of estrogen, tend to have the biggest emotional side effects I've seen. The NuvaRing, yes, some people anecdotally tell me that they've had better experiences with it, but any hormones you're putting into your body do have a whole body effect, even though like maybe they'll work more locally. So that is something I've heard, that people find that they have better experiences on the NuvaRing. And then people will also report that on just a progestin only pill, that they're better off, much more so than a combined pill.
Can I ask a question?
Sure.
So for a long time, there's been a stigma to mental health, and there's been a big push in the, in the world, to address mental health issues. I'm just curious, in your practices and in your experience, if you feel that there is still a stigma, or people are resistant to getting the help that they need because they're afraid of a stigma or afraid of what people might think.
I think it depends on the community that you're working in, and also the family that the individual comes from, their school, there are so many different circles of community. And so how each one of those circles feels about mental health and mental health treatment will impact that. I used to work at a clinic in Muncie, and there definitely seemed to be a lot more stigma there than my almost entirely non-Jewish practice, not in Muncie. But again, I think that we have communities within our larger firm community that there isn't the same stigma attached to it, and where they really are advocates for good mental health treatment and awareness of mental health disorders. So yes, there are going to be some people who are hesitant to get treatment. But I think that is changing slowly, even in communities that tended to view mental health treatment less positively. I think there is change happening also in those communities.
Right. I'll also add, I think the person who asked the question is from the same community that I am from. And I think it's changing. I think it's slow, but I think it's changing. I would say that that's based on the fact that I mostly treat kids, and people who will hesitate to seek treatment for themselves are much faster to bring in their kids. And then they'll say things like, well, when I was a kid, nobody took me for therapy. I just dealt with it. And I'm like, yeah, now you're an anxious adult trying to kind of make it so that your kids are not as anxious as you. So that's great. But like, it's very obvious that you didn't kind of grow out of it. You just kind of like are bumping along here. So I also think this is one of the reasons why I love doing talks like this to people in the community, because I think that is more of your role, because I can't see the stigma from where I'm sitting anymore. Like, I have a hard enough time like not accidentally like diagnosing people at my Shabbat table, like because it's so normal to me. This is what I do all day. I know that people with OCD, anxiety, and depression are just my friends. They just happen to not be my friends. So I think it's really important to be able to destigmatize these things from where you're sitting by saying, like, by just labeling things and identifying things and talking about things.
Yeah, I think that a step that all communities can take towards destigmatizing this is having educational programming about mental health. And it really kind of increases people's awareness and also the acceptance that this is something that people struggle with, and that's okay. And there shouldn't be stigma attached to it.
Right. Like 1 in 3 people will be diagnosed with an anxiety disorder at some point in their lives. Like 1 in 5 people will be depressed. Like those are huge numbers, like huge.
Mm-hmm.
It means like, like 1 to 2% of people have OCD, which sounds like a small number, but that means that like, right, like if you're in a room with 100 people, like there's someone else with OCD in the room too. Right? These are not like, oh, like let's look at the exotic animal in the zoo. These are people,
Mm-hmm. Yeah. Any other questions? Okay, so I'll jump into talking about OCD a little bit. So OCD can also play out in a number of different ways. And because with OCD, there are intrusive thoughts and subsequent behaviors to try to get rid of that intrusive thought or the anxiety that the intrusive thought brings on. Sometimes there will be repetitive behaviors that either you'll notice or she'll report to you when she's talking to you. So how you might see it is what we call reassurance seeking. So if a woman is asking you a question about her status or about anything, and then she asks you again and again and again, and like nothing you say seems to be enough for her. Like I've had women who asked me a question and we hung up, and then she would like text me a follow-up, like, are you sure this? Maybe I left out this detail. And then we got on the phone and we talked about it, and like, nope, no information had changed. She was just asking me the same question. And then I realized like, okay, she's just reassurance seeking here. So that may be something you'll notice. If a woman will constantly check if she is nida, so kind of in contrast to the example I gave before of a woman avoiding going to the bathroom because she's so anxious about becoming nida, a woman with OCD may go to the bathroom more often to check, like, well, maybe I bled now, or maybe I bled now, or, trying to kind of deal with that intrusive thinking that's happening. When women reach out with questions, sometimes it can be hard to distinguish at first what's OCD and what's like a legitimate halachic question about the details of the halacha. But if something strikes you as being like, why are you that worried about that level of detail? Then that could be an indication that there's OCD going on. And at the core of it is an intense discomfort with uncertainty. So if they're not like entirely sure that either they did the right thing or they understood what you said correctly, then they may become very distressed about that. And need to clarify multiple times, or these like ruminating thoughts may just repeat in their head over and over again, like maybe I didn't do it right, maybe I, whatever it is, insert in the blank space, whatever you think that might be. So whether it's like maybe I didn't do badiko the way I was supposed to do it, maybe I didn't prep for mikvah the way I was supposed to do it, maybe I didn't calculate my vestot properly, although that becomes a lot easier today with the mikvah calendar app. But if people are doing it by hand, that may be something that they also become anxious about. The Ramban actually has a beautiful piece in his Hilchot Nida that talks about how after a woman has gone to the mikvah, she should feel totally confident that she did what she had to do. Because there's no end to the number of doubts that somebody can have in their mind. So we don't want to engage in that type of thinking of trying to get to this complete and total certainty that people are sometimes trying to seek, because we can't get there. We can't ever get to a place of 100% certainty. So we don't even engage in this process of like going down this rabbit hole of rumination about like, well, maybe I didn't do this, or maybe I didn't do that. And I'll post it in the chat so you can all have that source. But it really is such a recognition of what goes on in some people's mind of if you leave any wiggle room for uncertainty, they become very distressed. So when women are reaching out to you with questions and it seems like there is an OCD type of pattern that's going on with them, or if a woman tells you, I have OCD, and I want you to know that, because many women will say that, it's helpful to not try to give in to their reassurance seeking or their request for you to give them absolute certainty about things. So you answer their question, but if they keep coming back with the same question over and over again, your response can be, we talked about this already. You know the answer. We're not going to go over it again. Because you want to, like Dr. Galanti showed that like cycle of having an intrusive thought and then the behavior, and it all kind of feeds into each other. When you just keep allowing for this behavior of seeking reassurance and trying to get to a place of absolute certainty, then it just boomerangs back up and creates more anxiety. And so you want to try to cut off that cycle to not feed into that loop that's happening. So really kind of cutting off the conversation, not answering the question over and over and over again.
I'll just also add, if it's okay, that OCD and specifically compulsions around mikvah are not religious observance, that there is a difference between being religious and being like, I guess, more observant and being compulsive. It does not bring you closer to God to do compulsions. So these people with OCD or struggling with OCD will be doing more and more and more bidikot, but it's almost like you can think of it as like it's an illness. It's not actually like, okay, now I feel better and I feel more spiritual. So the way I think of it is healthy religious practice brings you closer to God and builds your relationship. OCD doesn't do that. It actually comes from more of a view of like what's going to happen to me if I don't do this, right? So it's that constant doubt and that constant uncertainty of I was treating a woman who was saying, well, how many times do you, Dr. Galanti, how many times do you go through, I forget what it was, use Vaseline on the inside of your eyelids or something? And I was like, no, I didn't even know that was a thing that some people could do. That sounds terrible. but that's not my role, right? I told you to know your role. My role was like, okay, so I think you should call your rabbi and find out. My gut would tell me he's going to say 0, but you're welcome to check with him. And it's more like for people who have OCD about their mikvah observance, it's about calling a halachic authority and coming up with the things that they will do and only doing those things, whether it be like a time limit or whether it be like you go through these things once. The problem is through these things once is you said I could take 1 shower. You didn't say how long the shower was allowed to be. So, right, like it's, so I spent 3 hours in the shower, or like someone like, like it's very easy to, let's say, find, I don't know, if you have curly hair, your hair is never getting all the knots out. So like, there's no end to that. So it's more like with OCD, our goal is to kind of limit the compulsions as much as humanly possible. So the same question over and over becomes, like she was just saying, how do I not answer this question again? Because you can't get out of OCD with logic. You can't. It's just not possible. It's an emotional problem. So you need to be able to kind of help that person, at least in therapy, the goal is to help that person face their fear, which means doing less, not more. And honestly, that means like feeling like you're going to the mikvah completely unprepared, like, because that feeling is not based on logic, but it's a feeling, and I can't tell that person not to feel that way, whether or not it's based on truth. So like at a certain point, you just have to say, okay, like, no, it's time. We're moving on.
Thank you for that. Women will also sometimes do extra b'dikot for a hefsek tara as just a compulsive behavior. Like if they're afraid that, well, maybe there's a bit of red on it, I'm just going to do it again. I've had some women bring me a stack of like 7 or 8 b'dikot that they did for a hefsek, and like they were fine. Or the woman said, "Oh, I think they're all bad." So if that happens, you got to figure out what's going on there and why they're doing so many b'dikot. And for that woman, I said to her, if you get one that doesn't have any red on it, you may not do any more. It's bad to do more. And there is real halachic precedent for that, because a woman who does more b'dikot unnecessarily may actually injure herself and bleed because of the injury that she gave herself. And then she has a lot bigger of a halachic problem on her hands. So trying to cut it off as soon as possible, and clarifying that a halachically clean b'dika doesn't mean actually clean. It means no red on it. And so trying to make sure that that women are having the same definitions as you're working with when they say it wasn't clean, clarify what that means. Some women will also have a very difficult time making the call on if they are staining or flowing. So it is a very difficult area to answer questions in and to experience as a woman. And that uncertainty of, did I make the right call or not, can be very distressing. So for some women, it may actually be helpful if you just say, like, it doesn't sound to me like you've become nida, or it sounds to me like you have. And like that's what we go on. We don't approach halacha from a place of like absolute certainty, like I'm absolutely certain that you become nida, unless it is a very clear situation. But in these cases of it being a little bit unclear, you can like introduce that concept to her. Like, it sounds like you have become nida, as opposed to like, oh, 100%, don't worry about this. You are this. And for some women that may be uncomfortable, but it also will make her a little bit more used to the idea that like you can be pretty sure, and like that's good. And I'm not saying to be like rogue answering things that are, that are to give an answer without actually knowing what the reality is. But if like we come to the halachic conclusion based on like a pretty good sense of what's going on, as opposed to absolute sense, then it could be appropriate to share that with her. Sometimes women will prep their nails like way too much. Like they'll be uncomfortable that they don't know if the length of their nails is good enough, or if they're smooth enough or something, or if like they got all the hangnails off, and they'll just keep snipping or filing to the point of injuring themselves. And so if either you find out about that through conversations that you're having, or if a mikveh attendant turns to you and said, I've noticed that this woman comes with like, bloody fingertips every time she goes to the mikveh, then like there's probably something going on there. Somebody may have also body dysmorphic disorder, which is related, but it's basically intense discomfort with their perceived flaws or defects in their appearance that are not really perceptible by other people, but they're very aware of them. And so there can be like inordinate amounts of checking themselves, like in a mirror, examining what they look like. And somebody with body dysmorphic disorder can also have a particularly hard time going to the mikveh where they're in front of somebody else, and also then going home and attempting to be intimate with their husband if they are so uncomfortable with their body or a part of their body. So that may come up also. I've found that it's come up more with kallas that I've taught than with general women in the community. But if a kala seems super anxious about the wedding night or sexuality in general, that could be something also that could be going on. If women check themselves after getting out of the mikveh and they're like convinced that they had something on them that invalidated the mikveh, that's also might be a window into like finding out that they have OCD. I once got a call from a woman at 11:30 at night. I shouldn't have answered it, but it was a friend, so I did. And I happened to be looking at my
Welcome back, everyone.
Oh, sorry. I have no idea what happened. I'm just admitting everyone, and then we'll jump back to where we were. I apologize, everyone. I have no idea what happened. I'll apologize again when everyone connects to audio.
I'm going to throw some resources in the chat just about anxiety, OCD, general things. Why did only one of the links show up? I don't know, but
I apologize, everyone. I have no idea what happened there. All of a sudden, we got kicked out, so I'm sorry. I was telling you the crazy story about my friend who called me after the mikveh. She was in the mikveh still. And what happened was she said, if I find something on me after the mikveh, do I have to dunk again? And I was like, okay, like let's start from the beginning. What did you find? When did you find it? And it turns out that she had gone to the mikveh, she had gotten dressed, and then she thought, oh, maybe I had something on my body. So she got undressed, and in the corner of her toe, she saw a thread that had likely come from her sock. It was the same color as her sock. And so I said, don't dunk again. But the reason she was still there at 11:30 was because she was asking the mikveh attendants if she could dunk again, because she was certain that she had something on her. And the mikveh attendants were like, no, go home. You cannot dunk again. But she wouldn't trust them. So they said, call whoever you want to call to ask a question. And if they say that you need to dunk again, then you can dunk again. So she called me and I said, no, here, don't dunk again. But that was like so clearly an OCD type of behavior, that she was having such distress at the thought that maybe she could have had something on her. And logic would not have helped her, right? Like logic would tell her, this thread is from your sock that you put on after going to the mikveh. You had checked yourself beforehand. You were clean beforehand. You wore those slippers to the mikveh. It's like nothing got on your feet. But it's not a rational or logical disorder, which is the challenge.
Can I ask you a question?
Yeah.
So I've had the experience with someone who had OCD, not with Taras Mishpacha, with davening, where they were given the psak, like if you feel like you don't remember, if or you're not sure whether you said the same Talar Matzar or the same bracha, like for you, your psak is you cannot repeat it. So like whether or not you feel certain or not, you're not allowed to repeat it. So do you find like with women with OCD with the mikvah, like do you, if they're open to it, like do you work with them to give them a psak, like if you're nervous that you had something on you afterwards, you're not allowed to go back in, or like give them these type of limits, like you're only allowed to shower for however many minutes or brush your hair like 2 times or whatever, things like that.
Mm-hmm. Yeah, so we do place limits on people, like get out of the bath after X number of minutes. Like it shouldn't exceed that. Sometimes women will then be like sitting with a timer down to the second of like making sure that they're doing exactly what you told them to do. So, in some ways it's challenging, but it prevents them from just sitting in there for hours and hours. And same thing with preparations, like cut your nails, file them like no more than however amount of time, and hopefully that'll help. Sorry, I'm getting over a cold.
And do you like, if you're noticing from people's questions that they likely have OCD, but they have not straight up said that to you, like, do you, like, how do you navigate that? Like, you want to help them so they're not tortured in this process. Like, do you say, like, your questions are making me concerned that maybe you have OCD and we need to deal with this, or like?
So I wouldn't mention a diagnosis unless they tell you a diagnosis, but I would point out the behavior. I've noticed that you've asked me the same question 4 times tonight, or I've noticed that every month you ask me the exact same thing. Or, it's something like that. And then you can say, like, is this a pattern you've noticed in other areas in your life that you tend to like seek reassurance about what you're asking about? I just wanted to also go back to the after the mikvah. Should you tell them that they shouldn't dunk again? So I'm hesitant to say that as like a blanket rule, because there may be times that they really should be dunking again from a halachic standpoint. But you can work with them to figure out, like, is there actually any logical reason why she would need to dunk again? Usually not. And then I would be comfortable telling her, like, no, we're not doing this.
I'll also mention that obsessions and OCD latch on to the things that you value. So, right, like you can have OCD or obsessions about anything, but typically, like, if Taharat HaMishpacha is important to you, there's a good chance that you'll have OCD related to mikvah. Or, like if your relationship with your friends is important to you, or your kids, those are areas that your OCD will latch onto. And I found that Taharat HaMishpacha specifically ends up being a kind of unique area where it's easy for OCD symptoms to latch on no matter what you value, because if it's important to you to be a perfectionist, there's no area in halakha, I think maybe Pesach, which also OCD latches onto no matter what the area that you're OCD about. But there's room for perfectionism. If you're obsessive about your relationship with your spouse, then that's an area. If you're worried about your current children or future children, that's an area I can latch onto. So there's a lot of room to have intrusive thoughts in different areas of Taharat HaMishpacha. So, but they're not exclusive of each other. There are plenty of people who are who have like davening kind of obsessions and mikvah obsessions, and like worry about their locks. So sometimes you have very distinct patterns to your OCD, and sometimes the theme, like let's say if you're just perfectionistic and it comes out in 7 different ways, that's also very common. But if you know one person with OCD, the line in at least my field is like, one person with OCD. Everybody's OCD symptoms are very different from each other, because there's so many ways to try to kind of play whack-a-mole with your anxiety. So you have this thought like, oh, something bad's going to happen to my children. And OCD, because it's not logical, can say, okay, now turn this pencil 7 times, or it could be say like do this action, or it could be like, you know, make a special meal and make a special barach on it. Like, I don't know what OCD is going to tell the next person. Like, and that's, as a therapist, I find that really interesting and challenging and fun. I mean, fun loosely, but because it's very treatable, and I like dealing with things that are treatable, honestly. But it can be tricky. I think that's why OCD gets this rap of like it's people who wash their hands, which is not true.
Can I just share something quickly, Shira?
Yeah, go ahead.
A really good piece of advice that I received before I got married from my mom, who's on the call, and that I now shared with Carlos as well. Essentially, to like, I'm not OCD, Baruch Hashem, but just because we can all get a little crazy, but certainly it would be helpful for anyone who does have OCD mentalities, is that in your mikveh bag, you have your mascara and you have chocolate at all times in your mikveh bag. And as soon as you get back into your room, without looking in the mirror, you just swipe some mascara on your eyes. And the first thing you do after you leave and wash your hands is put some chocolate in your mouth. So when you get home and there's something, you find something, or even you're still in the room and you find something on your face, you can blame it on it, right? It's like, I touched the mascara was dirty, and that's why there's something on my cheek. Even though obviously it has nothing to do with it, but you have something to blame it on. Or the next day you find something between your teeth, and if you hadn't eaten anything, then yeah, you probably need to go back to the mikvah, but you ate chocolate, so maybe it was the chocolate.
An interesting piece of advice. I've never heard that before. Thank you for sharing that. Does anyone have any questions? I'll just add that also, was somebody about to ask something?
Yeah, it's not really, okay, I encounter this a lot with women who stain, but are not halachically nidah. And they feel very uncomfortable, right? And to me, I would use the word anxious, but not clinically anxious, but they are uncomfortable with the idea that, okay, I stained, but I'm really okay. Do you have any advice to tell women about that?
Yeah, I think it depends on the circumstances. Again, because I wouldn't have a blanket rule of like, oh, you stained, yeah, sure, go ahead, proceed as normal, because we do have considerations about how somebody should conduct themselves when they're actively staining. In terms of like abstain, if you see red, right? Like, we don't want a couple to have sex while she's actively staining. If a woman is in a situation where she's been staining, it was red, and it's clearly not happening anymore, then sure, she has a green light to have sex. Or if it's clearly not a problematic color, like if she's seeing a light brown, it's clearly not problematic, but she's staining, then sure, she can go ahead and have sex. But when I speak with women, I outline this for them, right? So like when a woman calls me and asks me a question about staining, I go ahead and preempt the questions of like, how will I know that I have the green light to go ahead? Because often people will feel uncomfortable asking that. But then it also breaks down for them in a very clear way, if we're still advising not having sex, or if we're saying, no, we think that it's fine for you to have sex. And often I'll tell women that the way you gauge that is if you do an external wipe with toilet paper prior to having sex and you don't see anything, or you just see a very light brown color, then that's fine. We do advise abstaining for about 24 hours after somebody initially sees a red stain. In a situation that they're like not expecting their period. If they know their period's coming and they start staining red, then we say like, just hold off until you see what's going on, because often their period does come. So it wouldn't be advisable to tell them, sure, just go ahead and have sex if you always have this pattern of like, I stain red and then I get my period. But if it's a situation that a woman will sometimes stain sporadically and then it won't turn into something, then there definitely is room for to say like, these are the guidelines of when you have the green light to go ahead.
So I understood your question differently because this is right. The halacha part is not my area, but the way I understood it was, let's say, a woman goes and gets like halachic guidance that this stain is not a stain, but it still feels like a stain, right? Like that's way more kind of my wheelhouse. So someone said this is okay, but it doesn't feel okay. And there's a famous psychologist, Jonathan Huppert, who talks about, I think he even might have an essay titled Sleeping with the Bacon. That's literally like on this topic, that we always in kind of anxiety treatment guidelines follow halacha, but within that we often do push patients to do things that feel uncomfortable and even a little icky, like within those bounds. So if, let's say, OCD latches on to kashrut instead, so right, like can't eat meat and milk together, or can't eat non-kosher meat, but there's no reason why you can't sleep with wrapped bacon under your pillow. I think spam is what they actually used. But that's kind of weird and uncomfortable anyway. And really, treatment, the way I see it, is making that distinction between things that feel wrong but really are fine, and then we push ahead and we do the opposite, and things that really aren't okay, and then we don't do those. Right? Like, I don't know, there are examples that sometimes I'll give, like if you take your a meat bowl and you have cold cereal and milk in it, that would make most people incredibly uncomfortable. Like, but it wouldn't necessarily be halachically problematic. So in treatment for OCD, sometimes we play with those lines instead of like, and we push people to do things that are outside their comfort zone for the sake of pushing their comfort zone, for the sake of, for the sake of like exposure treatment. So that's what we do there.
Thank you for adding that piece. Anyone else? Any questions or comments? I'll give you another minute to think about it, but I wanted to just say that sometimes when people have a baby, there is a particular time that they become very distressed, whether it reaches a threshold of a postpartum mental health disorder or not. Often it's a very difficult transition time. And so sometimes people feel this, especially for the first one, feel this need to have everything be fine, right? Like to present this image of like, well, I love my baby, so I must feel okay about everything that's going on in my life. But often people don't feel okay about everything that's going on when they have a baby. There are mixed feelings. And so just asking a question of like, how are you dealing with the transition? Can acknowledge that it is a transition, validate that there can be struggle there, and it gives an opportunity for them to respond in a way that is more real than just like, oh, how's the baby? And sometimes people will be hesitant to respond to more vague questions with how they're really doing, if they perceive it as more of like a social obligation type of question. Hi, how are you? Doesn't usually lead to, actually, I'm really not doing well. So having more of a directed question that validates the transition can be really helpful. And also with new kalas, sometimes that transition is really hard for people, and they might be hesitant to share that because they feel like, well, I just got married, I should feel totally fine, I should be totally happy with everything. But opening up the conversation to acknowledge that there is a big change that just happened, and I want to make sure that you're doing okay with it all. That could be really helpful for people in your community.
And also, right, just normalizing that, right?
Mm-hmm.
Normalizing that as much as people say like, oh, having a baby is great and having a baby is great, it's also really hard for many people, whether or not you have postpartum anything or not, right? And giving people a voice to say many people struggle when they're in your position and still love their babies. Or, you know, you're living with a man for the first time, like that can be a really big struggle. Like giving it a voice is hugely validating for a lot of people and can open up a door. So even more than asking a specific question, in therapy, one trick I use often is like kind of using sanitized versions of my own experiences to say, oh, when I had a baby, right, losing my independence was really hard for me. And I'm not going to go in with my patients to talk about like, yeah, like I probably had postpartum and I didn't realize, and looking back, like should have been more on top of that, but I didn't know because it was my first kid, right? Like I'm not going to do that with my patients, but I am going to give them more than I even expect that they might need, because if they do need it, it gives them like kind of a lifeline to be like, oh, okay, this is normal. I'm allowed to love my baby and also want to throw him out the window. Like those are normal. Like it's a normal feeling.
Totally. Okay. Any last thoughts, questions, comments? If you do think of anything that comes up, you can email me afterwards, and we can try to get back to you with our responses.
I'll also throw my email in the chat if anybody wants.
Great. Thank you.
And I put some resources in the chat if anybody wasn't here with the in and out.
Great. Thank you. Okay, so if there are no other questions, we will end the program here. Thank you, Dr. Galanti, for joining me tonight. As always, you were fantastic. You gave us a lot to walk away with. And thank you, everyone, for coming and for joining us. We'll see you next time. Bye.
Thanks for having me.